you.
Thank you. So we'll move on to neurocritical care cases and pearls. Dr. Klavansky will be leading today. Dana joined the department as assistant professor and associate director of the Neurocritical Care APP Nursing Education Program, and attending in the Neurocritical Care group after completing her BA at Boston University, MD at Saba University, residency in neurology at North Shore and LIJ, and then fellowship here in neurocritical care. She has a wide range of interests in neurocritical care, including subarachnoid hemorrhage and status, intracerebral hemorrhage and neurotrauma. And she'll be talking to us today, I believe, about brain death testing. Is that right, Dana?
Thank you for having me. Just one second, let me share my screen. Can everyone see my screen in presenter mode?
Yes, we see your slide. Thanks.
Okay, excellent. So yes, I'll be discussing brain death testing today, as well as updates in the brain death testing realm. So we'll start with a case. So this is a 46-year-old woman with no past medical history. She was found down at home and she was pulseless for an unclear period of time. CPR was performed in the field. They achieved ROSC in 20 minutes. Imaging at the outside facility showed a diffuse subarachnoid hemorrhage with intraventricular hemorrhage. It was a Hunt test 5, modified Fisher 4. They also saw that there was a questionable left vertebral aneurysm. She was transferred to us at the MSH Neuro ICU. And on exam, she was only breathing above the ventilator at the time. And unfortunately, she had PA arrest with ROSC at 4 minutes. On arrival to us, her blood pressure was in the 140s with a MAP of 108. She was tachycardic to 140. She was on 0.27 mics per minute of Levophed. Her alcohol and Eutox levels were both negative. And her labs were generally unremarkable, with a gas of 7.34, 35, 145, and a lactate of 3. Prior to the second arrest, for her exam, her pupils were 4 millimeters and unreactive with the pupillometer, absent corneals, absent vestibulo-ocular reflex, no cough or gag, no movement to noxious and no upper extremities, but she was breathing above the ventilator. After the cardiac arrest, her exam was unchanged, and it was still unchanged after EVD placement, several doses of 23% as well. Once stabilized, she did go down for a cerebral angiogram, but it was aborted because there was minimal intracranial blood flow and the aneurysm could not be adequately visualized. So what we encounter in the neuro ICU after this is quite common. Really, what are the next steps with these patients, and how do we speak to families, and how do we continue to manage the patient? So what I'll be discussing today, so a brief history of brain death testing, how to perform it, the newest guidelines which just came out in October of 2023, how to speak and explain brain death testing to families, and also skepticism and misinformation surrounding brain death testing. So this entire concept of brain death actually came about around in the 1950s and 1960s. And the first concept was actually put to paper in 1968 with a definition of irreversible coma. And it resulted because of this convergence of multiple areas in medicine in the 20th century. There were many ongoing discussions and controversies around this time about brain death testing versus what we really saw as the standard of death, which is cardiac death and pulmonary death. And these include advances in resuscitation and critical care, research into underlying physiology of consciousness, so understanding when a person is conscious, when they're unconscious, and what physical exam findings go along with that, and also concerns about advancements in technology, what the medical utility is around brain death, and the Pandora's box of ethics of end-of-life care that comes with brain death testing. So these concepts, this convergence of multiple areas, like I said, are resuscitation, critical care, coma and consciousness and unconsciousness, ethics, and also organ transplantation, which was which was also on its way up and up in the 1950s. So throughout history, irreversible loss of cardiac and lung function is what was classically seen as actual death. And this transition of heart to brain death grew from these developments in the 1960s. In the 1940s is when there was the first successful cardiac defibrillation. So something that we saw as finite suddenly, that we can bring someone back from the dead, essentially. In the 1950s is when the first ventilators were established, and also the first ICUs in the late 1950s were established in Pittsburgh and UCLA. With all these new discoveries and new findings and establishing of all these new medical marvels, we came into this dilemma of these comatose patients. They might recover, but some of them might survive, but be left in a devastated state. And then how do we manage them? How do we speak to families about these things? And what are the next steps? And it became this dilemma of a prognosis of death versus is it actually death? So the first criteria came about in the 1960s. So the first criteria were fixed and dilated pupils, no reflexes, and no spontaneous movements, in addition to apnea and also an isoelectric EEG. So those that actually met these criteria would be classified brain dead despite having cardiac activity still. This study looked at 90 patients in 1968, but met these criteria, and none of them ended up surviving. And in 1965, the first National Congress on Medical Ethics was held to formulate guidelines for end-of-life care for these patients. And this kind of in parallel worked because organ transplantation was also starting with the 1950s of the first kidney transplant. So of course, the surgeons who were performing these transplants at first were very cautious and uneasy about these patients who were technically not classically dead from a cardiac standpoint. Because of course you have to make sure that the patient is actually effectively dead before you do organ harvesting. So these clinical criteria were the first ways that surgeons would actually be more comfortable with performing organ transplants from technically dead donors into other people. So with this criteria in 1968, what was come up with was unreceptivity and unresponsivity. This was the central feature in irreversible coma, in addition to no movements or breathing and absent reflexes, and when it is available, a flat EEG. So with the coming up of this, with these practice parameters and the actual definition, there was actually a frustrating amount of back and forth between two major parties, which were saying either saying, is this prognostic but not equal to death, or was it actually death? And the bit of the frustrating part of this is that it did not actually end up providing a coherent definition of what brain death is. It kind of hinted that it could be brain death, but what it really provided was this ethically allowable way for patients to be defined as having an irreversible coma. So flash forward all the way to the 1990s, the AAN finally standardized it in what was called the practice parameters. They came up with 3 cardinal signs for brain death, which was coma or unresponsiveness, absence of brainstem reflexes, and apnea. So throughout this, there's a common theme of these clinical findings. And the apnea test protocol the guidelines for it were finally established, along with the role of confirmatory tests if the patient for some reason was not able to have some of the aforementioned tests done. And it was updated in 2010 and again in 2023. So how do we declare brain death? So these are the new guidelines that recently came out. So there have been several changes in these new guidelines. So now the age is greater than 37 weeks by corrected gestational age. In addition, it has to be a catastrophic, permanent, identifiable etiology for brain injury. So these are things that we see quite commonly in the unit. So TBI, subarachnoid hemorrhage, intracerebral hemorrhage, KB infections. You have to rule out mimics for brain injuries, so things that are reversible. So Guillain-Barré, leptomeningeal carcinomatosis, and a high C-spine injury. If there is consciousness or evidence of some kind of brainstem preservation, don't perform these tests. If it's reasonable to wait about 24 hours after the brain injury before you initiate brain death testing. And the same really applies for after any kind of medical or surgical interventions. It's waiting a sufficient amount of time, so around 24 hours is reasonable to ensure that there's no recovery of brain function before you go along with brain death testing. And if there's a primary posterior fossa injury, there should be evidence of a catastrophic supratentorial injury before brain death testing is initiated. The patient should, as in the prior guidelines, be rewarmed to 36 degrees Celsius, and you should wait 24 hours prior to testing. They should have a reasonable blood pressure, so systolic greater than 100 and MAP greater than 75. If they classically ran on the lower side, then it's okay for it to be a little lower than that. In terms of tox agents, so you want to exclude intoxication or if they've been on a high dose of any sedating medications. So you would want to employ the 5 half-lives rule, but you also have to be cognizant of things like if they were hypothermic or their age, so they can more slowly metabolize sedating medications. And you would also want to send levels such as a pentobarbital level to make sure it's below the detection limit before you start testing. You also want to make sure they're not paralyzed. And in terms of electrolyte and other metabolic disturbances, if a patient is normally hypercarbic, like if they're a COPD patient or something like that, they're never going to have a CO2 of 30, 35. So within the grand scheme of things, it's okay for them to be hypercarbic at their baseline. And sodium and other levels should be within a generally normal range. And pregnancy is not a contraindication to brain death testing either. In terms of the clinical exam, so on our modern day brain death testing, so there should be no evidence of responsiveness, no brainstem reflexes like I showed with our patient. If they have a high C-spine injury, don't test oculocephalics. And the motor exam should only show spinal reflexes. And if the patient's less than 6 months, then absent sucking and rooting reflexes as well. So for actual apnea testing, once you've determined that the patient doesn't have any brainstem reflexes, so an arterial line is preferred, so you can have accurate blood gases throughout and you're not concerned about like a mixed venous gas or something like that. So you want to pre-oxygenate them to 100% with 100% FiO2 for at least 10 minutes and get a gas prior to starting to make sure that all of the numbers are within range, such as the pH, the PaO2, and the PCO2. The way we provide apneic oxygenation virtually all the time is disconnecting the patient from the ventilator and delivering 6 liters per minute of oxygen through a nasal cannula through the ET tube. For about 8 to 10 minutes, you want to then watch for any kind of symmetric chest rise. And then you recheck the gas after 8 to 10 minutes. With the new guidelines, they have to meet all of these criteria. So the PaCO2 has to be greater than 60 and 20 millimeters of mercury above the starting CO2, and the gas pH has to be less than 7.3 in order to be able to declare the patient. So back to our case. So the patient is oxygenating well. She was disconnected from the ventilator, and she was already on an epinephrine vasopressor drip. Unfortunately, she still had a precipitous drop in blood pressure. It dropped to the 80s within a few minutes. So she was disconnected. She was connected back to the ventilator. The blood pressure normalized. But then when it was attempted again, the patient again had a precipitous drop in her blood pressure, so they could not complete apnea testing. So the question is, what do we do now? So with her, ancillary tests had to be performed. So these are only done if the exam or apnea testing for some reason can't be performed. So if there's severe craniofacial trauma, so you can't appreciate the cranial nerve testing, if you can't correct metabolic derangements for whatever reason, or if they become hypoxic, like with our patient, hypotensive, or they develop cardiac arrhythmias from the apnea testing. If the patient is hypothermic or is still on CNS suppressing medications, you should not perform ancillary testing, and you should wait for that to get out of their system or for them to be rewarmed. Also, if there's skull fracture or defects, that's also not a reason, as long as they're otherwise testable elements of the brain death exam. So with the updated guidelines, there are three acceptable ancillary tests. So 4-vessel catheter angio, radionuclide perfusion scintigraphy, and also TCDs. So we are all familiar with 4-vessel catheter angiography. So this is a gold standard perfusion study. It allows for direct and dynamic flow assessment, and flow really arrests at the point of entry into the dura in both the anterior and posterior circulation. This is due to the tamponading from the ICP, which is increased beyond the map. For radionuclide perfusion scintigraphy, so this is widely used. It can be done in both adults and children. So these two compounds that are used are lipid soluble and they're brain specific, and they allow for demonstrating presence or absence of intracranial flow and cerebral perfusion. As we can see here in the bottom picture, the hot nose sign. So there's increased nasal signal due to there's a functional occlusion of the ICAs and the flow is diverted back to the ECAs. With TCDs, so this is a widely available for brain death testing. It's used in children, in adults only. And what you see in someone who has cerebral circulatory arrest, so they have oscillating, what's called either oscillating flow in the bottom picture or systolic peaks in the proximal large intracranial arteries. And these are both consistent with brain death. So with small systolic peaks, you only see the systolic portion of the entire sort of flow. And with reverberating or oscillating flow, there's this to and fro motion. So it's essentially net zero cerebral blood flow. The patient has to have, of course, good windows to perform these TCDs, and you need to document 2 separate TCD studies 30 minutes apart. And your second one would be the time of death. So with our case, it was inconclusive, unfortunately, because there was a concern for diastolic flow versus some kind of like artifact pattern in especially the right MCA territory and the right ICA territory. So in the first picture, that's your classic systolic peaks, which were in the left MCA. And in the right MCA, it was thought to be potentially due to the EVD that the patient had, which slightly normalized the ICP. Because on the M mode of the TCD studies, it was more convincing that it was actually, there was cerebral circulatory arrest, but because of this concern for diastolic flow, a secondary study had to be done. There was a study that showed the sensitivity and specificity of TCDs with brain death testing. It was about 70 and 97% respectively, and some patients needed repeat TCD exams in order to confirm brain death. As for unacceptable tests, we have EEG, CTA, MRA, and auditory evoked potentials and somatosensory evoked potentials. I didn't discuss the last one in this talk just for time purposes, but we'll discuss EEG and CTA. So for EEG, previously to actually determine brain death, extracirculatory arrest extracerebral arrest had to be demonstrated on EEG. The sensitivity had to be set at 2 microvolts, and there had to be 2 double distance electrodes 10 centimeters apart for at least 30 minutes. And this had to be done concurrently with somatosensory or audiovisual stimuli. The issue with EEGs, though, is that it can be easily altered by sedating medications and multiple other factors. So even before the EEG, the epileptologist has to be very comfortable reading these EEGs. So that's why it's really not considered one of the modes of testing for brain death anymore, and also doesn't properly evaluate brainstem function. For CTA and MRA, although it is a much more convenient way to evaluate than taking a person down for angio, the available data really doesn't demonstrate a good amount of validity for these. And there's a potential for false positives. This is because of a variation in protocol. There's different sensitivities, specificities, et cetera. So it's not a consistent test that can be used for it. So other additions in the new guidelines. So the clinicians that are involved in procurement of organs should very reasonably not be involved in the determination of brain death. The person who is performing the brain death evaluations should be deemed competent to perform them. It should be someone who in their training has done it many, many times. And trainees should be directly supervised by an attending. and at least one examiner is required. In previous variations of the parameters, there weren't really specifics as to how many people should be performing it. In addition to this, there should be a process to really resolve disagreements with families. There are a lot of emotions during these, a lot of misinformation. So it's really important to speak to families about these and make sure everyone is on the same page. And also the determination of support after brain death. And you have to also provide a reasonable period to accommodate families as well after their loved one passes. Although we do not need to consent families for brain death, it is very reasonable to inform families that we are going to perform it. In addition, we should let families know that there could be spinal reflexes that could be observed. Families really think that these are the patient's, natural movements, that they could be getting better, but unfortunately that's not the case, and we need to make them aware of that. As I said before, we should provide families with reasonable amounts of time with the patient before discontinuation of organ support. And this could be a lecture in itself, but with pregnancy, discussing and educating families about risks and benefits to the fetus is very important and should be a multidisciplinary discussion with MFM, child neuro, and neonatology. So how do we explain brain death? It's a long, complicated process and a lot of discussions with the family. So it starts with, of course, when we see that the patient has a devastating permanent brain injury. Live on New York should be contacted for patients who have these poor exams. And then it involves multiple discussions with the family. So the first one should be really discussing with them about the poor prognosis and really planting the seed of brain death and the idea of testing it. If the patient does meet criteria, then Alani has to be notified again. And you also have to make sure that there are no confounders prior to testing. Again, let the family know that you're going to be doing brain death testing. And then if you successfully do brain death testing and doesn't need any ancillary testing, then that would be the time of death when it's complete, when you get that second blood gas after the 8 to 10 minutes. Then you let the family know of the results and let them spend time with the patient while Live-On approaches them. And then you either remove the patient from the ventilator or they proceed with organ donation. And though it's not time of death, we still have to document the time of cardiac standstill. Furthermore, explain again, so the time of brain death is the time of actual death, and the certification filled out with the time of declaration is not the sensation from cardiac activity. And after reasonably accommodating the patient and their families, the ventilator and any other medications or hormone replacement is stopped. There's a lot of skepticism, a lot of misinformation about brain death and how we test it. When I was looking for information about this, just one Google search, and there's like 10 pages of misinformation, even on PubMed, about how brain death testing is actually performed and the validity of it. And there have been multiple high-profile cases surrounding this. Two notable ones are Aiden Hailu. So this is a case where the parents objected to discontinuation of organ support. And this was in 2015, after there have been iterations of the practice parameters already out by the AAN. But the Supreme Court in their state said that this may not actually be valid. So organ support was actually continued. They actually overruled these standards that neurologists and other doctors across the country and across the world had come up with. The patient suffered a cardiac arrest, so that's really that's how this case was actually finally put to rest. And another very prominent one was Jahi McMath. So this was a girl who suffered a cardiac arrest after a hemorrhagic shock from a complicated tonsillectomy. And the mother actually objected to discontinuation of organ support, even though she did meet the criteria of death by neurological criteria. And the mom was actually able to transfer the patient to New Jersey, because they have different rules there about what constitutes brain death, and they're accommodating there for various reasons. The legal battle for this was like over 3 years until the patient did pass in 2018. There have been also studies about the variability of brain death protocols in the United States. So this is a study from 2016, and it actually demonstrates why protocols are so incredibly important and especially in something like this. So as we can see here in the first figure, there's a wide range of people who can perform brain death testing, and it's really not clear how comfortable or how, the validity of the people doing the brain death testing, how much training they actually have in it. And then the prerequisites for clinical testing. So in 7% of these, they didn't require any absence of any sedation or paralytics. And in 13% of them, they had no established cause for brain death. And in like 45% of these, there was also no indication of whether patients should or should not, can or can't be hypotensive during brain death testing. So there was unfortunately, a lot of variables in this. In addition to apnea testing, so in like all the criteria that we discussed, the liters per minute, the final CO2, only in about less than 40% did they indicate how many liters per minute the patient should even be oxygenated to. And as we discussed, it's very important that the patient has a final CO2 of greater than 60 millimeters of mercury, but only 35% of these had any mention in their protocol about what the final CO2 should even be. And even the rewarming, the temperature that a patient should be prior to any testing, only like a little more than like 35% actually indicated something. And in terms of which tests should be performed, it was also all over the place. So which test should be performed, EEG, radionuclide study, angiogram, TCDs, there was a lot of variability into which test was approved and which one was not approved. With our case, what was done was the radionuclide perfusion scintigraphy, since the TCDs did have questionable flow, possibly due to the presence of this EBD. There was absent perfusion and compound activity. This is due to the lack of metabolic activity in the brain, which was consistent with brain death in this patient. So while the TCD did have questionable flow and they were not technically consistent with cerebrocirculatory arrest, from a metabolic standpoint, the patient was brain dead. So the time of the completion of the radionuclide scintigraphy is when the patient was declared. So, and finally, with brain death exams, so it's very important to document brain death exams. So on the left is just a standardized death note when a patient suffers usually a cardiac arrest. But on the right is the much more extensive documentation that we have to do. And it's just another indicator of how careful we have to be when we do declare a patient as brain dead. So we discussed all these neurological findings already. And because she couldn't tolerate the apnea testing, we also have to document the cerebral perfusion imaging, which did officially declare the patient. That's it. Those are my preferences. Thank you.
Dana, I have a question. So in addition to the importance of applying brain death testing standards consistently nationwide, it seems like a major portion of public acceptance of this would be on the legal side, and very clear legislation that defines brain death testing beyond just AAN standards. Do you know if there are lobbying efforts by the AAN to try to codify this more clearly so that there aren't these Supreme Court battles that supersede AAN standards?
I think that was the goal of these parameters that just came out. I think that was to codify it much more clearly. And I know that there's separate papers and committees that are also involved specifically with brain death testing and with organ procurement as well. So I think that was really the goal of this latest paper that came out, to really codify it. Because before there was still a lot of gray area. So I think that this paper was really what was meant to codify it and make it much more clear.
So Peter, the legislation that defines death is called the Uniform Declaration of Death Act. And this past year, there was an effort to sort of come together and try to update it to make it clearer that brain death was equivalent to cardiac death. And that actually, I think a month or two ago, they actually had to halt it because there was so much input from the pro-life community that it sort of fell apart. And there was a concern that the declaration of death might actually become weaker if everyone tried to update the laws. And so that's now indefinitely on hold. So there was an attempt, but I think the physicians and lawyers seemed to feel after some of the initial talks that this was a dangerous road to go down at this point.
I think it really highlights the importance of, right now we have to work with each family and educate them and try to make the situation work. But until it's codified legally, that's going to have to continue to be the case.
Any comments from the neurosurgeon clinicians who have to deal with this a lot on the vascular side, trauma side? Zach, are you here? Chris?
Yeah, I thought that was really great, Dana. Thank you. I know we've had a few interesting cases over the last few months. Are there circumstances where the brain death testing is confirmatory, but we can't move forward with end of life because of patient, family, religious beliefs? I recall encountering that scenario a few times over the years. Can you discuss that?
So we have had that issue. I think even when I was a fellow, we had that issue several times. At that point, we're really, as far with my experience, we've had to get ethics involved once the patient is actually declared, but the family is still refusing to disconnect the patient. As I said, there are accommodating facilities in New Jersey that the patient can technically be transferred to if the family feels really strongly about that. Yeah, that's as much as that's been my experience personally with it, that the patient just has to be transferred to a facility that can accommodate them. Yeah.
It's not that uncommon that this does occur. And we often
To answer your question about the specificity of neurotrauma, Dr. Betterson, I don't know. I can speak for the fact that at Elmhurst we have a lot of hemicraniectomized patients, and yes, indeed, it is an issue because the TCDs will remain with a little bit of forward flow, and we've had several cases with the nucleide study also showing through the craniectomy site a little bit of residual tissue that is perfused in the cortex through the scalp, and even a CTA positive showing some arterial flow, but actually the brainstem was completely gone, and we still declared the patient. So yes, neurotrauma makes a lot of complexities, making it even harder to declare patients because of also the skull base fractures, making you have the caloric testing not reliable. So you have to resort to an ancillary test, but then which one is the best? And actually all of them, I would say, in the presence of a craniectomy are not valid.
Good. Okay, great presentation, Dana. Thank you.